Okay, so today my topic is the management of pregnant women with epilepsy, a multidisciplinary approach. Today I will tell you from the talk article, and I decided that I will do the summary of the Green Talk guideline because talk article is more exclusive. And I think when you read the talk article, because it is more recent, 2017, this article came after the Green Top guideline, and this article talk about the what is the recommendation of the Green Top guideline. So I think it's better to read this talk article and see because it is more concise and exclusive. Okay, so I will start from the talk article. The talk article 2017. First of all, introduction. As we all know that epilepsy is characterized by recurrent unprovoked seizures resulting from excessive neuronal discharge. Okay, and we also know that it affects 0.5 to 1% of women of childbearing age, and it is the most common serious neurological condition in the pregnancy. It is the most common, and anti-epileptic drugs are the mainstay of treatment, and they have been given 1 out of every 200 pregnancies. So in the UK, fortunately, two-thirds of women with epilepsy, they remain stable during pregnancy and 96% will deliver a healthy baby. However, some women with epilepsy, pregnancy may be associated with increased risk of significant maternal and perinatal mortality and morbidity. Okay, so why is improved care in women with epilepsy in pregnancy is important? It is important because there are a number of new cases of epilepsy per year in young women is 20 to 30 per 100,000. And the risk of mortality, pregnant women with epilepsy is almost 10 times higher than that of the general population. In the Green Top guideline, also it's written the same. It's 10 times higher mortality rate. Okay, and the Mabrace UK report found that epilepsy was not only the most common neurological cause of death, but also it was associated with a mortality rate greater than any other single pre-existing medical condition. So please, this is very important that it is the most common neurological cause of death, but also 2015 Mabrace tell it is the mortality rate is more than any other medical disorder. It is the mortality rate is more than that. Unfortunately, the maternal mortality rate for pregnant women on anti-epileptic drug is of the order of 60 per 100,000. And it is not improved since last decade, despite urgent calls to improve services and care for this group. So these figures, this 100 times, sorry, this 10 times higher than general population, this is important. And why the problem is so important, and every exam I think 1 or 2 questions will come definitely because epilepsy is very favorite and it is very important topic. So clinical practice guideline, a critical appraisal. Actually, they in this talk article they said there is a Scottish guideline, and they compared the Scottish guideline as compared to Green Top guideline. So I think this table is not important because they discussed the comparison. They did comparison with type of evidence, how many systemic reviews were added in the RCOG in Scottish guideline. So I just use this, what type of tool they use. They use the agree to global rating tools, and which is reliable and widely accepted tool for rapid appraisal of guidelines. So for any guideline appraisal, this tool is, they said they are using this tool. And even in the by clinician daily practice, if they want to compare two guidelines, even in the OSCE exam, sometimes they are giving you studies or any guideline, and they ask you, actually in the MRCG Part 3 exam, they ask you do the critical appraisal of the given article. So you should know these things. This tool consists of 5 domains that assess the guideline reporting, and each domain is scored out of 7. I didn't put that table because at that point, I don't think so that table is important. Okay, so already we did this one. Why is preconception care is important? What element should be included? Now, the 2015 Mabrace UK report ascertained that 86% of women with epilepsy who died of sudden unexpected death in epilepsy, SUDEP, have not received pre-pregnancy counseling. And preconception counseling is recommended as routine practice because it will improve the epilepsy and non-epilepsy related outcome for both mother and baby, and should be involve coordinated interdisciplinary communication. Now they talk about this communication should be neurologist, physician, general GPs, and obstetrician. But definitely half of the pregnancies are unplanned, as we know. So at this time, before getting pregnant, this is the time when any woman of childbearing age with having epilepsy, you can, even if she's coming to the GP, at that time you can talk about having a pregnancy and what should be the precautions. So first of all, you have to reassure the woman that 96% of the pregnancy they have good outcome, and the women who have been seizure free for more than 12 months, they likely to remain seizure free if they are compliant with the treatment. So this is important. If they are fit free for more than 12 months or 1 year, that's mean and if they are compliant, that mean that 90% of chance that they will have good outcome. And then we have to inform the woman preconceptional counseling that this some women they need dose adjustment to maintain the seizure control because of pharmacokinetics of the pregnancy. Now, most women with epilepsy can aim for vaginal birth unless there are obstetrical issue. And epilepsy is not an indication for induction of labor or cesarean section. Now this is a table. This is a table actually in the TOG article. They have given this table. They discuss the effect of pregnancy on epilepsy. So if the patient have epilepsy and she get pregnant, what will happen? She will remain seizure free 60% of the time. In 17%, the seizure frequency may increase. 16% seizure frequency may decrease. And there is a risk of intrapartum seizure 3.5%, and status epilepticus it is less than 2%. So I think you need overall you need to take overall idea, because these figures are not so important, that you have to think that majority of the women, two-thirds of the women, they will remain seizure free, and there is a slight increased chance that they may have increased frequency, or even they have a chance that epilepsy will improve. And intrapartum seizure, risk of intrapartum, this figure is important because intrapartum, when you are managing patient actively, you should know that there is a 3.5% chance that she can have seizure. So this is important figure. I think this one is important. Now, factors contributing to the deterioration of the epilepsy during the pregnancy. First of all, if the patient epilepsy is poorly controlled prior to get pregnant, this is a poor prognosis. And if she has seizure frequency of greater than one per month, this is also a poor prognosis. Or if she has multiple seizures type, if she has drug-resistant epilepsy, or if she's taking high-dose polytherapy, or if she's not compliant with the drugs, or because in pregnancy there is reduced drug concentration due to increased clearance and metabolism. And also there is a pregnancy specific triggers because of nausea, vomiting, it will decrease anti-epileptic drugs, and also sleep deprivation, labor, hyperventilation, pain, it will all precipitate the fits. So these are the poor prognostic factors for the deterioration of the epilepsy. So what will happen to the baby? Risk to the developing fetus, generally low risk to the fetus. There is an increased risk of major congenital malformation due to anti-epileptic drugs. However, lamotrigine, tiracetam, and carbamazepine are commonly used and are considered the safest agent. Sodium valproate, it infers the highest risk of major congenital malformation, especially the neural tube defect. And there is also an increased risk of cognitive difficulties, learning difficulties in children of mothers taking sodium valproate during pregnancy. So we already discussed, this is just I put because of revision and because better to revise. So that's why I just I'm just repeating. We already discussed all these things. So risk of epilepsy on the fetus, there is a risk of hypoxia, injury from falling during the seizure, risk of SUDEP, and the risk is dependent on the dose and number of anti-epileptic drug. We will discuss this table later on. Also, there is an increased risk of IUGR in mothers on polytherapy with anti-epileptic drugs. So what is the risk of developing childhood epilepsy? What is the risk of inheritance? Increased risk of epilepsy if first degree relative have epilepsy. So there is an increased risk if like first degree relative, like if brother and sister or siblings, they have epilepsy, then this child will have increased risk. Also, it is depends on multi-factors and depends on what type of epilepsy it is. So individual genetic susceptibility will be discussed with the patient neurologist or this is new terminology, epileptologist. Medication 5 milligram folic acid should be taken preconceptionally and throughout the pregnancy to reduce the risk of congenital malformation and long-term cognitive defects. So I was seeing the discussions and because in the Green Top guideline, it's written that you have to take the folic acid before getting pregnant, at least 1 month before, and at least minimum at first trimester. And it's minimum first trimester, you have to continue 5 milligram folic acid. And here in the TOG article, it's written that throughout the pregnancy to reduce the risk of congenital malformation and long-term cognitive defects, because long-term cognitive defects, mostly it is in the third trimester. So that's why there is some controversy. I want to clear that in the guideline, which I remember, it was written that minimum at least at the end of the first trimester. And here in the talk, it's written throughout the pregnancy to reduce the risk of congenital malformation. So I think this is the safest choice, better to continue throughout the pregnancy. Avoid any abrupt withdrawal of anti-epileptic drugs. Okay, and also we have to aim for monotherapy with the lowest effective dose. And also if taking sodium valproate, we need to consider weaning off or alternative drugs on the advice of neurologist or obstetric physician. And if we need to continue because there are some diseases, there are some type of seizures in which we need sodium valproate. If need to continue, need to change the moderate release or increase the daily frequency to reduce the risk, the high peak levels of the drugs. So doses greater than 800 milligram per day are associated with greater risk of teratogenicity. This is also important. The doses, higher doses, which is greater than 800 milligram, it is related with the greater risk of teratogenicity. So first line should be avoided. This drug should be avoided as a first line. And unless other treatments like not ineffective or intolerated like lamotrigine, levetiracetam, and carbamazepine. And also, we already discussed, it's written the guideline that every pregnant patient, they have to register in the epilepsy and pregnancy database register. This is the national database register. So table how to optimize the health preconceptionally. This is some summary. First of all, patient need to be compliant and close contact with neurological team and avoid seizure triggers. And then lowest possible dose and aim for lowest low dose monotherapy if appropriate. And then need to avoid changing medication if a woman is seizure free unless on the advice of neurologist, and close discussion with the patient. Also, we can change the drug to the less teratogenic drug like these three drugs. And also, if other drugs are appropriate, avoid sodium valproate. Also, sometime need optimal serum concentration sometime. So general health, definitely BMI, alcohol consumption avoidance, regular exercise, stop smoking because risk of preterm labor, and 5 milligram folic acid several month preconception. Now you can see here they are saying 5 milligrams several month preconception. The guideline is written at least 1 month before and at least the first trimester. This is the minimum requirement. But here written at least several months before, better it's several months before. Sometimes some medication, sometime we are starting sorry.
Excuse me, ma'am.
Yeah.
Excuse me, ma'am. For the
Yes, yes.
also said that 3 months prior, 3 months prior to the conception, it is taken folic acid 5 milligrams.
Yes, yes, 3 months. I was about to tell you that majority medications, the 3 month period is considered safe. Like for example, there is, if the patient have taken the methotrexate, they are saying wait at least for 3 months. For example, if they have taken injection methotrexate, they are saying at least for 3 months. Like that, there are some conditions in which they are saying better to take 3 months before. There are some condition we will see later on, which condition at least 3 months before pregnancy you should start taking the folic acid. So this is something written in the talk article, but the guideline they are talking about the minimum, at least minimum. Okay. Anti-epileptic drugs and pregnancy. I will discuss with you the summary of the guideline also. Because this was latest, that's why I started this one first. Anti-epileptic drugs and pregnancy, majority they cross the placenta and are potentially teratogenic, and the incidence of major congenital malformation in women with epilepsy who are not exposed to anti-epileptic drugs is similar to general population. We discuss in the guideline that if they are not taking anti-epileptic drugs, the risk of malformation is same like general population, 1 to 3%. That's mean if the patient have epilepsy, it itself doesn't increase the risk of major congenital malformation. And also they talk about if the children, if the mother taking anti-epileptic drugs, their children have up to 10% risk of major congenital malformation compared with the general population. So if the mother is taking anti-epileptic drugs, the risk of having major congenital malformation is 10%. Okay. In the guideline, they write if taking polytherapy, it was 17%, and I think something 7% also will check because I'm very poor in number. But however, they are talking about 10% overall. Okay, so potential toxicity can occur with anti-epileptic drug in any trimester, and it is highest risk of fetal harm is highest in the first trimester, and the risk of cognitive impair typically occur in the third trimester and is associated with the polytherapy. This is very important. Sometimes we can forget this thing that this cognitive impairment actually it can develop typically occur in the third trimester. And if you remember, if we are giving the steroids, now the new steroid guidelines in which they are giving the steroid after 37 weeks, they are telling maybe there is more chances of neurodevelopment delay. It is given in the third trimester. So even in the third trimester, some drugs can yani, cause cognitive impairment or neurodevelopmental delay. So this drug, even some drugs, especially this sodium valproate, it can even third trimester cause cognitive impairment. The extent of fetal risk is influenced by type and dose, and maternal age and parental history of malformation. There are three things. If mother is epileptic, her age, and also dose and type of epileptic drug. So what are the defects, including oral defects, oral clefts, cardiovascular defect, urogenital defect, and neural tube defects? And minor defects are there is fetal anticonvulsal syndrome in which there is a dysmorphic features, hypertelorism, hypoplasia of the nails, digits, and the midface. Okay, so they also have an increased risk of SGA.
Hello.
And also, yes, hello, yes. Any problem? I don't know. Okay, fine. So I was talking that the risk is twofold: increased risk of being SGA if they are taking this. This is same in the guideline. That guideline also talk about the risk of having SGA twofold increase. And that's why you can do surveillance for fetal growth in women who are taking moderate dose of polytherapy with anti-epileptic drug. Although the RCOG recommends that serial scan should be performed from 28 weeks of gestation for all pregnant women with epilepsy taking anti-epileptic drugs. For example, if the woman is having epilepsy, but she's controlled and no fits for the last 1 year, and she's not taking anti-epileptic drugs, in that case, she's not high risk for SGA. So this is they are trying to say that if she's not taking anti-epileptic drug, and if she's taking anti-epileptic drug, and if she's taking anti-epileptic drug, the risk is twofold. So for high risk women who is taking anti-epileptic drug, you will do serial scan, which is recommended by RCOG. And also the systemic review say there is an increased risk of miscarriage, antepartum hemorrhage, hypertensive disorder, induction of labor, cesarean section, preterm delivery, PPH compared with the background population. But I remember we discussed that the risk of GDM and perinatal death is not changed. Only these risk factors were increased, but GDM and perinatal death remain same. So when to avoid or when to postpone the pregnancy, when the seizures are uncontrolled in the preconception counseling, especially tonic-clonic, you will advise against the pregnancy if she's taking very high doses, if she's taking multiple, if she's having drug-resistant epilepsy, or if she's not compliant. So these are the condition, and also if she has other comorbidity. Now you can see here, if she's not taking any anti-epileptic drug, the risk of malformation is almost 2 to 2.3 or 1 to 3%, 1 to 3% almost a background risk of general population. So if she's taking carbamazepine, the risk of cardiac defects is 2.2 to 5%. Okay, and it is dose dependent risk of for facial cleft. Breastfeeding is safe, and pregnancy is considered safest drug, this carbamazepine. So they can ask which one is the safest, but all here written safest. Carbamazepine, lamotrigine also safest, and levetiracetam is also considered safest, and oxcarbazepine, it is considered relatively safe. Okay, breastfeeding, all the drugs are safe, and all have this cardiac, all have cardiac defects, facial clefts, only the levetiracetam, they have chances of neural tube defects. And you can see here 1 to almost same, there is no difference, 2 to 5%, 2 to 5%, little bit higher for carbamazepine and lamotrigine cardiac defect, 2 to 5%, 2 to 5%. So this facial cleft, it is dose dependent risk. Okay. So yeah, this is what we have. What is safe anti-epileptic drug practice in the pregnancy? And definitely this is something determined by type of epilepsy. And already we discussed this thing. And already we discussed that there is a 10% risk. So they are repeating the things. Okay, so what I want to tell you that clobazam, it also used for exacerbation of seizures during pregnancy or in the postnatal period, and is considered relatively safe. So this drug, if during the seizure, during the pregnancy or the postnatal, you can add this clobazam. However, there may be some women with epilepsy. The only effective anti-epileptic drug is valproate, and in these circumstances, the benefit of valproate for seizure control may outweigh the potential risk to the fetus. So, after careful discussion, you should only be used. And also, we already discussed these two drugs. They are first line. Okay, so what about the plasma monitoring? Because they said there is a physiological adaptation, and there is hepatic enzyme induced metabolism, increased renal clearance. So anti-epileptic drug decreases during advanced ages. That's why, especially the most common drug which is affected by this pharmacokinetic of pregnancy are lamotrigine and levetiracetam, carbamazepine, and oxcarbazepine. So these all drugs, they are affected by the pregnancy pharmacokinetics. However, the true clinical implication of this are uncertain. So we have to do dose maintenance. Okay, so this one is decided by the specialist. With the exception of these four drugs, plasma monitoring is not required unless there is a change in frequency. So for these four drugs, because these four drugs, and especially this one carbamazepine and this last two drugs, they are enzyme inducing drugs. So these two drugs, especially, they said we need monitoring, but if the patient is using another drug, only we will do drug monitoring, drug level monitoring if clinical decision, if there is a poor compliance, if there is a change in seizure frequency. Otherwise, only for these four drugs, other drugs we are not doing the. Actually, in the guideline also it's written that it's only the clinical decision that according to the situation of the patient, if there is a worsening of the condition and if clinically you think that patient need monitoring of drug level, then you will do. It is an individualized decision. So that's mean if there is an increase in frequency, vomiting, poor compliance, medication interaction, then you will consider. Routinely, you will not do. This is very clear. because in some unit the serum level may not be available, and also sometimes it is inconclusive. So better to titrate against the clinical symptoms and seizure control. So routine monitoring is not recommended. Okay, what about the steroids? Because in the guidelines written that you will not double the dose, but here in the talk article is written that if your patient is using enzyme inducing anti-epileptic drugs or require antenatal steroids, you will double the dose 48 milligram over 12 to 24 hours, but routine doubling of the dose is not recommended. So if the patient is taking enzyme inducing, then you will do double dosing, otherwise you will not do. Okay, and you will only give 10 milligram oral maternal vitamin K if there is an additional risk factor for hemorrhagic disease of the newborn. For example, if the maternal liver disease or anticipated preterm delivery. If you remember, we discussed the intrahepatic this ICP guideline, in which also we discussed that we will give only give vitamin K if there is a deranged coagulation profile or a severe liver disease. Routinely, we will not give. So same is the case. If there is additional risk factor, then we will give vitamin K. Otherwise, routinely we will not give vitamin K for the epileptic patients. And also, there is insufficient evidence for routine maternal vitamin K to prevent hemorrhagic disease of the newborn or PPH. Okay, so also we already discussed this thing, so it's only repetition. Analgesia, there is a low threshold for epidural analgesia, pain relief like TENS. This is I think this transcutaneous therapy. Antonox, regional anesthesia. Avoid the use of pethidine during labor as it may be epileptogenic. This is a very common exam question, that in pregnancy, in epilepsy, if you want to give analgesia during labor, you will not give pethidine, you will give diamorphine, because pethidine itself, it's a epileptogenic. So better to avoid this one, and instead you can give 5 milligram of diamorphine. So antenatal care, we will see that we need the antenatal care multidisciplinary team, and we discuss in the guideline that any obstetrician who have a special interest in epilepsy, or if the any physician who is trained in the maternal medicine, then neurologist definitely, and then obstetric physician where available, GP, anesthetist, midwife, or epilepsy nurse specialist, she should involve. Okay. So first antenatal appointment, you have to take history. We'll discuss first point in the history we should ask. Also fast track referral should be done, and neither RCOG nor sign guideline, they recommend fetal echocardiography in pregnant women with epilepsy due to lack of available evidence. But because we know that the anti-epileptic drugs are associated with cardiac malformation, especially if they are taking polytherapy. So ISOG is the International Society of Ultrasound in Obstetrics and Gynae, and they are especially related to fetal medicine units, so subspecialty. They are considering fetal echocardiography in high-risk women the gold standard for detecting congenital cardiac malformation. These guidelines state that the structural cardiac abnormalities, such as the defect commonly associated with anti-epileptic drugs, are commonly missed with routine anomaly scan, as some abnormalities are not evident from the four-chamber view alone. So today even I have one case, the patient have epilepsy, and we did anomaly scan, and we mentioned to the sonologist that this patient is taking anti-epileptic drug and she is high risk for anomalies, and they missed the diagnosis of cardiac abnormality. And I think now at 30 weeks, the some, I don't know who diagnosed this cardiac, the patient have multiple, yes, after delivery, and after delivery baby becomes cyanosed, and then postnatally they diagnose that the baby have transposition of the great aorta, any, she baby have multiple abnormalities, so not in the chambers, but because of major vessels, maybe that one is maybe involved. So it's real that you can miss the cardiac abnormality in the routine anomaly scan. So in this case, if the patient is very high risk, and she has multiple risk factors, so better in that situation, special situation, you can consider fetal echocardiography. So maybe in the exam, maybe they will give you the high risk scenario. Maybe in that scenario, you in the EMQ, you want to select consider fetal echocardiography, it will be correct. because this is ESOG. ESOG is also subspecialty website, and they are talking about, they have their own guidelines. And I think in some situation we are taking guidance from the ESOG guidelines. Okay, so what we will ask from the patient, definitely, this is very important even for part 3. Whenever there is any medical, maternal medicine related station, talk, station, you will ask any medical problem, you will ask that when the last time the neurologist or cardiologist see the patient, okay? And when was it, when was the condition was diagnosed, or what type of seizure she has, focal, generalized, non-convulsive, unclassified, what is the frequency, when was the last seizure, and which medicine she's taking, what doses, and what are other features of seizures. She has triggers, aura, activity during seizures, or is there any history of status epilepticus or ITU admission. So this thing you can ask from the patient. So in this talk article, they make comparison between SIGN. This is the Scottish guideline and RCOG guideline. Okay, SIGN guideline, they are saying folic acid dose 400 microgram, and if the patient is not on anti-epileptic drug. RCOG is saying 5 milligram prior to conception until at least end of first trimester. So when in the exam they are saying there are options coming that continue throughout the pregnancy. This is if they are taking anti-epileptic drug, this is by TOG article. And but in the guideline they are talking about at least, that's mean they are agree with if you want to continue throughout the pregnancy, but at least minimum is first trimester. Okay, so they said SIGN guideline, they said 5 milligram if on anti-epileptic drug, or if not an anti-epileptic drug but high risk. For example, she has family history of neural tube defects or BMI is high. So in this condition, you will give the 5 milligram dose for folic acid. Okay. Then anti-epileptic drugs, definitely you will increase the dose of lamotrigine in the pregnancy and reduce postnatally, because again postnatally the pharmacokinetics changes. They also say the routine monitoring is not recommended. Individualize the patient. Routinely you don't monitor, but you can individualize. They said consider dose adjustment of levetiracetam and other anti-epileptic drug if there is a change in seizure frequency or if suspecting toxicity. Then you can consider dose adjustment. But SIGN guideline, they consider increasing dose of lamotrigine as a routine. But we will follow the RCOG guideline. Okay. Antenatal steroid, if woman she's taking enzyme inducing who require antenatal steroid, they should receive the double dose. Okay. But RCOG guidelines saying routine doubling of the dose is not recommended. Okay. So what about oral vitamin K? Consider 10 milligram vitamin K if there is an additional risk factor like maternal disease or anticipated preterm delivery. So here also insufficient evidence for routine maternal vitamin K to prevent the same thing. Both are saying the same thing. Ultrasound, they said insufficient evidence to support the use of routine ultrasound third trimester unless a SJ baby is clinically suspected. In RCOG, they said start from 28 weeks if the patient is epileptic on anti-epileptic drugs, as the odd ratio is 3.5. So there is a 3 times higher or 2 times higher chances of developing the SGA baby. So especially in this high risk woman, you have to better to do growth scan. Analgesia, low threshold for epidural, and they are also recommending the regional Antonox 10s and pethidine avoid, and because it may be epileptogenic, and you can give diamorphine. Okay, so that's it. So intrapartum care, you need to reassure the patient the risk of intrapartum seizure is low. This is, I think, a recall question. 3.5% risk of seizure during labor. And however, for all women on high risk, the consultant unit is advised, and patient should be admitted early in the labor, and IV line and one-to-one midwifery care. And it is important to have adequate analgesia. Hydration and compliance, stress avoidance, hyperventilation avoidance, sleep deprivation should be avoided. Also, they talk about epidural, and because if you will, seizures need to be treated promptly because it can lead to the maternal and fetal hypoxia and fetal acidosis. If there is a seizure in the labor, what you have to do? You have to give the benzodiazepine, which is IV lorazepam 2 to 4 milligram bolus doses. You can repeat it 10 to 20 minutes. Okay, so you can repeat 2 to 4 milligram of bolus doses 10 minutes, every 10 minutes 2, or every 4 minutes 20 milligram, or whatever the way you can give. So you can give every 20 minutes. Or IV diazepam 5 to 10 milligram in slow bolus if lorazepam is unavailable. So you can give slowly 5 to 10 milligram, because one this ampule of diazepam is 10 milligrams. So you can just either divide into give slowly. Left lateral, manual displacement of the uterus, oxygenation, and continuous electronic fetal monitoring. This is what you need to do. If there is a refractory case, definitely you can start IV phenytoin. Loading dose is at 18 milligram per kg. For example, if the patient weight is 100 kg, then you have to give loading dose of 180 milligram. And then you have to increase by 5 milligram per kg to a maximum rate of 50 milligram per minute. So maximum rate is 50 milligram per minute is the one. Or loading dose is 18 milligram per kg, and you can increase 5 milligram per kg accordingly. So postnatal care, the absolute risk of postnatal seizure is low, but higher than the risk of seizures during pregnancy. So during pregnancy, as compared to pregnancy, the postpartum risk is higher, but overall absolute risk of seizures in postpartum is low. Okay, so definitely the same triggers for as during the labor. And also, if the patient is taking anti-epileptic drug, the team of epilepsy should review the patient within the first month of delivery, because maybe they need dose adjustment. Okay, so because now we already discussed this why dose adjustment needed. And also breastfeeding is actively encouraged as the concentration of most anti-epileptic drug is minimal. But caution is advised who are taking polytherapy, phenobarbital or benzodiazepine, or if the patient have preterm babies who should be closely monitored. So in these situation, you have to be very cautious if polytherapy, phenobarbital or benzodiazepine, or if the preterm babies. Okay, so this is for breastfeeding. Now for contraception, you can use this Mirena, levonorgestrel releasing intrauterine device, copper T, and medroxyprogesterone injections, because these are not affected by enzyme-inducing anti-epileptic drugs. So what I am doing, I am remembering bus only these three, that okay, we can use better to remember which should not be used, because all other you can use, but only the OCPs. If you are using the enzyme inducing drugs, OCPs and progesterone only pills you should not use. Otherwise, the this Mirena and this copper intrauterine devices, barrier methods you can use. But implants and this medroxyprogesterone injection, they are category 2. They are category 2, that the benefit is more, and you can use because the benefit is more as compared to become pregnant again. So it's category 2 medroxyprogesterone and implant. But this OCPs and progesterone only pills, it is category 3, because the risk is more. Okay, risk is more. Why risk is more? Because enzyme inducing drug, what will happen, that they will decrease the level of this contraception hormones in the blood, and that's why the contraception will be ineffective. That's why those women on non-enzyme inducing drugs, for example, lamotrigine and levetiracetam, can consider estrogen-based preparations. So they can consider, you can consider for them. Sudden SUDEP in epilepsy in pregnancy. SUDEP is a death that is unrelated to trauma, especially drowning or status epilepticus. It is unrelated to trauma, drowning, or status epilepticus. Unfortunately, it is the predominant cause of death in women with epilepsy. So, Mabre's report highlights that the risk of SUDEP is higher than expected in the women with epilepsy. So, modifying risk factors such as compliance for drugs, first aid training of the family member, and avoiding sleep alone. We discuss all this in the guideline, reduces the risk. So there are concerns regarding the use of lamotrigine, as the incidence of SUDEP in women with epilepsy taking lamotrigine is higher than those taking other anti-epileptic drugs. So this 2.5 per thousand patient year, if you will see, is as compared to 0.5 to 1 per thousand patient years. So this is if there is a one patient die per thousand because of SUDEP, if the patient is taking lamotrigine, the risk is 2.5 per thousand. It's more, almost double, more than, yes, almost double. So explanation for this higher risk include the relative common use of lamotrigine and the reduced serum drug level with advancing gestation potentially resulting in an increased seizure frequency. So lamotrigine is very much related to there is a chance of decreasing concentration during advancing gestational ages. So they said the risk of SUDEP is more with the lamotrigine. Okay, so this is the pathway, antenatal care pathway. They give this one in the guideline. No, it is from, sorry, it's not from the guideline, it's from the TOG article. So if the pregnant woman, she become pregnant with epilepsy, 5 milligram folic acid at least until end of first trimester. This is RCOG. Okay. And if she is taking anti-epileptic drugs, what you will do? You will manage as high risk with shared specialist care. Both RCOG and sign guideline, they are agree on that one. So this we already discussed: neurologist, obstetric physician, obstetrician with a special interest in epilepsy, GPs, epilepsy nurse, midwife. Then you will individualize the frequency of visits and input of specialist and based on severity and stability of epilepsy. At each visit, what you will discuss and consider at each visit, you will see other specialty pediatric if she's taking multiple anti-epileptic drugs, or if there is a concern of congenital malformation. Anesthetist, if she's on polytherapy, anti-epileptic drugs, or if there is a concern that she will have medication who is interferes with anesthetic agents, or there is a previous issue with anesthesia. A neuropsychiatrist, if patient, sometime women with epilepsy may benefit from their input also. It is based on clinical experience. Okay. Then every visit you have to tell them avoid seizure triggers, ensure compliance, assess frequency. Every visit you will consider anti-epileptic drugs level and titrate the dose. For example, if she's on lamotrigine, or if she's on levetiracetam, or if she is having seizure frequencies increase, so accordingly you will decide. Vitamin K, if an enzyme inducing drug, if high risk for hemorrhagic disease of the newborn like liver disease or preterm delivery anticipated, the sign guideline is saying in this condition you will give vitamin K. For RCOG, they say insufficient evidence, but sign guideline, if there is a risk factor, you will give vitamin K, otherwise no. Now, okay, this is for, now they talk about that you will do ultrasound. In ultrasound, you will consider echocardiography according to ISO guidelines. If high risk, for example, congenital cardiac defects or polytherapy, you can consider echocardiography 18 to 24 weeks. You can consider. And serial growth scan for from 28 weeks, RCOG said if the patient is taking anti-epileptic drugs, then you will do fetal growth scan from 28 weeks. Okay. And here they are talking about if she's not taking anti-epileptic drugs, if she's seizure free for greater than 10 years, and or if she's not taking any anti-epileptic drug for more than or equal to 5 years, then you will consider as a low risk woman that like she's don't have epilepsy. And accordingly, if she has any seizure, then you will label her as a high risk. Otherwise, you will just consider as a low risk. Okay. And if she's seizure free, khalas, low risk. If she's not seizure free, then again you will refer the patient to the high risk. Okay, again seizure, refer the patient, like that. So okay, so now this is TOG article. Okay, this is this I took this green top guideline. I think better to revise the green top guideline here also, because yesterday day before yesterday, so we discussed already the prevalence of epilepsy is 0.5 to 1%, and the risk of death increased tenfold in pregnancy. And also Mebre's report, they told the SUDEP is the 14 women out of 14, 12 women dies because of SUDEP. and fetal congenital defect is more if the woman is taking anti-epileptic drug. It's like summary. Okay. So diagnosis, we already discussed, it is by medical professional who has expertise. And also, if patient don't have seizure for last 10 year or last 5 years, she's not taking anti-epileptic drug, she is low risk woman. And also, okay, this we already discussed. So this is the table, you can see the table. This is just repetition. Okay, so we discussed that there is a differential diagnosis whenever there is a epilepsy first time fits during the pregnancy after 20 weeks. Then you have to consider also, along with eclampsia, you can give treatment magnesium sulfate, because if you don't know before getting investigation, if patient came to you and there is no previous history of epilepsy, then you can give magnesium sulfate. But at the other differential, it was cerebral venous thrombosis, press, space occupying lesions. So this was in the differential, and also metabolic problems also. So risk of congenital malformation in women with epilepsy not taking anti-epileptic is same, almost same. It's almost like 2.8%. Okay, in the guideline. Okay. So already we discussed these are the disorders which is associated with anti-epileptic drugs. And also sodium valproate, it is associated with neural tube defects, facial defects, and hypospadias. Phenobarbital and phenytoin with cardiac malformation. Okay, so there are some risks which is especially with some drugs. So for cardiac malformation, more commonly with the phenobarbital and phenytoin with cardiac malformation. Sodium valproate, they have neural tube, they have facial defects and hypospadias. And again, with phenytoin and carbamazepine, cleft palate in the fetus. Okay, so if there is a fear of inheritance, genetic counseling should be done. Okay, so in the guideline, we discussed that highest with sodium valproate, already in the talk article also, they tell this, the risk of major congenital malformation is 10%. With lamotrigine, it is same like a baseline general population risk, 2%, and carbamazepine, 3.4%, and with levetiracetam, it is 0.7%, very low. Okay, risk of recurrence for major congenital malformation was 17% if the previous baby have major congenital malformation. So if you remember, I told you there are 17% if the patient is taking 14 if polytherapy, that the risk of major congenital, yes, polytherapy, it is taking the risk is 17%. And also if the previous baby have congenital malformation, again the risk is 17%. Okay, so these are the sum of the percentages. There is no other way except you just try to memorize them. Okay, if we already discussed, if women are taking carbamazepine, phenytoin, lamotrigine, there is no developmental delay. Okay, but with sodium valproate, verbal IQ and performance IQ is low, and there is an increased rate of autism also. Here they talk about 5 milligram folic acid in the preconception, at least 3 months preconceptually. Okay, this also from the guideline. They talk about if the patient is seizure free for 9 months to 1 year prior to pregnancy, there is a chance 74 to 92% that they will remain seizure free. Okay, so almost 2/3 of women, they will not have experienced seizures during the pregnancy. This is also from the guideline that generalized epilepsy 74% and focal 60% seizure free in the pregnancy. So there is a more chance of seizure free if they have generalized epilepsy. If they have focal epilepsy, it is 60%, little bit more chance. Okay, so already we discussed all this thing. I think no need to repeat. Okay, so routine monitoring is not recommended, or okay, this thing already we discussed. that when the patient have been taking medication of anti-epileptic drug, we have to ask her about every visit also about the depression, low mood, because these are the side effect of anti-epileptic drugs, poor concentration, tiredness, irritability. So in this case, if they give you in the exam the any scenario patient is taking anti-epileptic drug, now she presented to you with these symptoms, so maybe you want to select perinatal mental health team. Okay, so obstetric complication already we discussed that no difference in perinatal death and GDM. Okay, and there is an increased risk of induction of labor, PPH, and IUGR. Also, miscarriage, APH, hypertensive, induction of labor, cesarean, preterm, IGR, PPH increase. Also, again, SGA baby 3.5 times higher. So we need to do serial scans if the patient is taking anti-epileptic drug. Routine monitoring with CTG is not required. Okay. So if baby, they are taking, mothers are taking hepatic liver enzyme reducing drug, you need to give vitamin K 1 milligram to decrease hemorrhagic disease of the newborn after delivery of the baby. Usually they are giving vitamin K to every baby. And the doses of steroid in the presence of liver enzyme reducing drugs not required. So you see here is the difference. Here is the difference. The difference is in the SIGN guideline, they are recommending the doubling the dose. SIGN guideline, Scottish guideline came in 2015. So they are recommending, but the RCOG guideline, they are not recommending. And the TOG article, it's only comparing the both. So they are not giving any conclusion what you need to do. So I think when the patient is taking multiple drugs and maybe she's taking 2 or more enzyme inducing drug, maybe in that case you might want to consider, they didn't recommend, you might want to consider. But if she's I think this is the right answer. Otherwise, if she's taking a single drug enzyme inducing according to RCOG guideline, it's the doubling dose of steroid is not recommended. So go with the RCOG guideline, okay? But in complicated scenario, you must consider that in the TOG article, they discuss this thing. Timing and mode of delivery should be reassured that most will have complicated labor and delivery, and definitely diagnosis of epilepsy is not an indication for induction or cesarean. Intrapartum care, that okay, we need to consider that there is sometime if there is a firm diagnosis of non-epileptic attack disorder, especially they have seen that if the woman having history of epilepsy, they have this non-epileptic attack disorder type of diagnosis. Sometimes they are having attacks. Okay, so you need to avoid giving these women anti-epileptic drugs or delivery if they you have already this diagnosis. And also labor, during the labor they talk about 3.5% risk of seizure, so labor risk is low. And definitely avoiding the trigger factors, same thing we are repeating again and again. And during the labor the risk is 1 to 2% the labor, and postpartum it is 1 to 2%. Here again it's different. In the TOG article they talk about 3.5% during the labor and in tonic-clonic seizures. But in the RCOG, they talk about it's 1 to 2%. So somewhere between 1 to 3.5% the tonic loss in the labor. Postpartum, again, it's 1 to 2%. In the TOG article, they talk about the risk of having fits postpartum is low as compared during the pregnancy. So, but absolute risk of having fits postpartum is low, and only risk we are concerned about during the labor. In the article 3.5%, here it is written 1 to 2%. If the patient have seizures, what you will do, you will give them benzodiazepine like clobazepam. Okay, and sometime you consider to give prophylactic clobazam, for example, if the patient have recent convulsive activity, or if she has recent history of seizures, or she has history of seizures in the previous labor. Even if she has a history of seizures in the previous labor, so this is important. For example, they give you history that the patient is having epilepsy. Now she came in the early labor and she give you the history that she has seizures in the last pregnancy. So what you will do in this may be EMQ, because usually these type of scenario coming in the EMQ. So before giving the answer, you should know the answer. If the patient have previous history of seizures, in this case, you have to think about prophylactic clobazepam. I don't know why I written it's clobazepam. Okay, so prophylactic clobazam is considered if recent fits of, or if recent history of seizures because of precipitating factors, or if history of seizures in the previous labor. Or definitely seizures can cause hypoxia and maternal hypoxia, fetal hypoxia, and acidosis secondary to uterine hypertonus. So okay, again the same thing they are repeating. So only you will do continuous fetal monitoring if the patient is having high risk of seizures. Otherwise, you can do intermittent monitoring also, and you will do continuous fetal monitoring if there is an intrapartum seizure, or if there is a high risk of seizure in the labor. Okay, so any seizures lasting for more than 5 minutes can progress to status epilepticus, which is affecting the 1% of the pregnancy. So what is the treatment? Treatment is you will do make mother left lateral, high maintenance of airway oxygen, and IV access. You will give the lorazepam, which is 4 milligram bolus, and you can repeat 10 to 20 minutes. So it's about zero point 0.1 milligram per kg. Okay. So according to weight, you can give, or you can give in the talk article it's taken 2 to 4 milligram or 4 milligram, 10 to 20 minutes. Diazepam same 5 to 10 milligrams slow IV, and if there is no IV line, you can give 10 to 20 milligram per rectally. You can repeat after 15 minutes, or you can give repeat if there is a risk again, or you can give midazolam 10 milligram as buccal preparation, or lorazepam IV you can give. So they are most commonly we have diazepam available. So I think this is the most commonly used drug, IV diazepam. Valium, which is the name of Valium, is available most of the time, or you can give parectally, or if buccal preparation is available, midazolam 10 milligram. If seizures is not controlled, you can give phenytoin or phosphenitoin. So dose here is loading doses. In the talk article, it's written 18 milligram per kg. Here RCOG, they are writing 10 to 15 milligram. Okay. So adult dose is 1000 milligram. This is the maintenance dose. But I remember they are giving like something bolus dose first, and then they are giving the maintenance dose. So the maximum dose is 1000 milligram, or the in the talk article it's written 50 milligram per minute. If there is uterine hypertonus, you can consider abortocolysis. Recommended labor analgesia, we have transcutaneous electrical nerve stimulation, Antonox, oxygen mixture, and nitroxide mixture, regional anesthesia, and the diamorphine should be used in preference to pethidine. And there is no contraindication for induction of labor, or a consultant-led unit should be the one with place of delivery, because we might need maternal and neonatal resuscitation. Continuous CTG monitoring in low-risk women, intermittent monitoring can be done. Postpartum management, peripartum, first 3 days, maximum seizures exacerbation. So first 3 days, because first 3 days, what happened after delivery, there is a more stress, dehydration, and lack of sleep deprivation. So first 3 days, there is a high chance. And the maximum risk to those who have seizures 1 month prior to pregnancy. So these women, they have the maximum risk, okay? And if doses of anti-epileptic drugs were decreased, you have to consider to decrease within 10 days postpartum. Also, it was written in the talk article that after 1 month should be reviewed by the epileptic team. After within 1 month, the doses of drug, because postpartum 1 month, maybe they need to bring all the doses back to the normal, or maybe they want to change the pre-pregnancy drugs. And also they said doses, if it was increased, it has to be decreased 10 days postpartum. So any patient with epilepsy, the postpartum plan of drug management, I think it should be written in the plan that what she will do after delivery, what should we do about the doses. Okay. So the transfer rate to neonates through placenta and breast milk it depends. The fetal accumulation is mildly increased for levetiracetam, valproate, and gabapentin. So for these three drugs, it is mildly increased: gabapentin, sodium valproate, and levetiracetam. So babies may show sign of drug withdrawal. Remember these three drugs, they are non-enzyme inducing. Most easy way to remember which drug are enzyme inducing is to remember enzyme inducing drug, because they are less in number. So rest of the drugs, they are non-enzyme inducing. I remember by this way. And I told you there are three P's like pyrimidone, phenytoin, and I think there is one more P. And the three drugs was carbamazepine and the same name like oxycarbazepine or like that. So these were enzyme inducing drugs. So these carbamazepine, okay, babies for these three drugs, levetiracetam, valproate, and gabapentin, babies may show drug withdrawals. Sodium valproate and carbamazepine and phenytoin, they have minimum transfer in milk. So you have to remember, either you make formulas or whatever, you just remember or read again and again. These three drugs, the accumulation is increased and the baby have drug withdrawal symptoms. And sodium valproate, carbamazepine, and phenytoin have minimum transfer. So lamotrigine, levetiracetam, and topiramate, they transfer to large extent to child through the milk. So these three drugs, there is a higher chance. And if, but better you breastfeed the baby, especially they talk about lamotrigine. They said better you breastfeed the baby and then you take the drugs is the best way, especially for lamotrigine. So although the lamotrigine have a higher extent of mother to child transfer through the milk, but you can breastfeed the baby first and then you can change the timing of the drug. So in this way, lamotrigine, you can, with lamotrigine you can breastfeed the baby. So postpartum safety advice, because we want to avoid accidental injuries, and there are some precautions how to breastfeed the baby, how what should we do. It should be reinforced in the postpartum period. And what we need to do, screening for depression, 29% risk, more risk for depression as compared to 11% for control, especially if they are multi-parent. Taking polytherapy, risk of depression is increased. So contraception, okay, so IUCD, Mirena, and Depo, this injection, they are not affected by enzyme inducer. So if the woman taking enzyme inducer like carbamazepine, oxycarbamazepine, phenytoin, phenobarbital, and pyrimidone, I remember, and the third one was topiramate. These drugs, the expected failure rate of OCPs is 3 times. It's 3.1% women year. Okay, so the level of estradiol and the levonorgestrel reduced by carbamazepine, which is enzyme inducing, oxycarbamazepine, and if topiramate, they are taking low dose 200 milligram per day, it doesn't interact. So higher doses, it interacts for topiramate. Also, what you can do if the woman is taking OCPs and she's taking enzyme inducing drug, what you can do, you can increase the estrogen to 70 microgram, or you can decrease the pill free interval from 7 to 4 days, or you can do tricycling. Yani you give continuously for 3 months the drug, and then you will have withdrawal after 3 months. So you can do like this. Okay, so barrier contraceptive is advised with oral contraceptive pills, this progesterones, and for the patches, rings, and progesterone implants. Okay, why they are advising barrier contraceptive? Because maybe they want additional, additional this one additional barrier. If the patient is taking anti-epileptic drug and she want to continue with oral contraceptive pills, pop or transdermal patches or vaginal rings or progesterone implants, they have to take this barrier contraceptives. For emergency contraception, copper IUCD is recommended, because you can advise double dose of levonorgestrel, because single dose is 1.5 milligram. So you can double the dose 3 milligram within 72 hours. For doubling the dose of ulipristal acetate is not recommended. Okay, and oral hormonal contraceptive can alter the efficacy of some anti-epileptic drug by increasing the metabolism. Like for example, oral hormonal contraceptive increase the metabolism of lamotrigine. Okay. Oral hypocontraceptive use has been associated with a 25 to 70% decrease in lamotrigine trough levels, with a drop of more than 20% in the first 3 days after taking the pill. No change in concentration with POPs. So with lamotrigine, if you are the risk of taking OCP is very high, because OCPs will decrease the level of lamotrigine 25 to 70%. So there is increased chance of fits if a patient is taking OCPs and is taking lamotrigine. So the chance is 25 to 70% decreased level of lamotrigine. Okay, but lamotrigine can be taken with the POPs. Okay, lamotrigine is non-enzyme inducing drug, so this you have to remember. With lamotrigine, you can take this oral progesterone pills, but with lamotrigine, the OCPs should not be used. Why? Because OCPs increases metabolism of lamotrigine, and lamotrigine is non-enzyme inducing. Okay. Okay, so this depot implants and Mirena. There are reports of true contraceptive failures in women using anti-epileptic drugs and progesterone in only implants, implanon and explanon. Okay, so this is the table. You can see here, if patient is taking enzyme-inducing drug, OCPs and progesterone is 3 and 3. Any risk is more. But with progesterone only implant, benefit is more. It's 2. Benefit is more. Okay, and injection also 2. Benefit is more. So you can give a depot or norethistone steroid. Depot is more safe. It's 1. The one and the another type of there is depot and there is another one, norethistone and enthate. The risk is 2. So depot is most safe, and Mirena and the copper. So these 3 drugs is safe for enzyme inducing anti-epileptic drug. Please remember, because sometimes they're asking about depot in the exam. I remember they give me this question, which drug you can use with patient taking enzyme inducing. So the answer was depot. Don't forget depot. Okay, it's 1. Even implant, if there is no other option, even implants, it's 2. Yani risk is less, benefit is more. Okay, and rest you can see all the methods for non-enzyme. All the methods are 1 1 1. You can use all type of contraception with non-enzyme inducing drug, and with non-enzyme inducing drug only lamotrigine, because lamotrigine OCPs cause metabolism of lamotrigine, and there is a fall 70% fall in level of lamotrigine. So for OCPs, lamotrigine is 3. Otherwise, for other drugs, POP and implant and all is 1. Here, this one is important. Don't forget lamotrigine and OCPs. And here, don't forget these 2 drugs. And here, implants in case of enzyme inducing anti-epileptic drugs may be, for example, in some scenario, patient is for example very obese, or patient don't want amenorrhea, or patient don't want to take depot injection, or patient is not willing. I remember the patient is saying she don't want injection, something like that. In that case, you can select the implant. If she's enzyme inducing drug and she wants something a long term contraception, and she's refusing and she don't want to take injection, so in that scenario, instead of using depot, you can select the implant. Okay. Okay. So any questions? Anything? I think I revised so many times. Until now, you must remember many incidences and many things. Anything you want to ask? Okay.
Ma'am, I want to ask something.
Okay,
That
ask.
I'm living in Pakistan, Sialkot, and
Uh-huh.
my telegram is not working. properly. I am adding my number again and again, but it's not showing anything. So from where I can get all these videos and
You
recordings?
subscribe the YouTube channel, because this channel I put all the videos in sequence, na?
I subscribed it.
Uh-huh.
But I don't know why other videos are not showing. Only one is visible, that is miscarriages, guideline for miscarriages.